In order to talk about changing the paradigm or the way we treat pain, we first really need to understand what is pain. The definition of pain, according to the International Association for the Study of Pain, is that it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Now let's just unpack that definition just a little. I've highlighted in red the words that I really want you to pay attention to. And so pain is a sensory and emotional experience. It's not or. It's not one or the other. It is always both. And so when someone comes to us in pain, we need to look at objectively both their sensory experience, their tissue-based experience, which is where they feel the pain, but also their emotional experience. And we need to measure that objectively, just as we objectively measure their range of motion and their strength. In order to do that, you need to use psychosocial questionnaires, and we'll talk a little bit about those. But for more information on that, the Level 3 course will delve into that on a more thorough basis. The other thing I want you to look at is that pain is associated with actual or potential tissue damage. And so the analogy I give my patients is that when we run across the street and sprain our ankle, we have torn the anterior talofibular ligament potentially, and that causes some local tissue swelling and inflammation. And we are often, and not always, because people can sprain their ankle and not have a pain experience because there may be something in the context of what's happening, like a bus is barreling down on them as they cross the street, that is more important than actually protecting that ankle. When a bus is barreling down on you and you've sprained your ankle and the option is to fall onto the street and hold onto your ankle, our stronger survival instinct would say, doesn't matter that I just tore the anterior talofibular ligament. What I really need to do is to run across the street and get out of the way of this oncoming bus. So pain is always a contextual experience, and sometimes it actually talks to us about actual tissue harm that we have done. I prefer to use tissue injury versus tissue damage. Damage sort of connotes a permanence to it, whereas injury is a transient thing. We injure ourselves, it heals, we get better. And so I do like the word injury better than damage. But actual tissue injury, we understand. Potential tissue injury, the pain is just as real. If you take your index finger and you pull it back as far as you can until pain stops you, your brain produces pain in that moment, not to protect you from actual tissue damage, but to tell you that you are approaching damage, and that pain is just as real and is experienced in terms of damage to the body. That's what it feels like. You've done something, but you understand and you know logically at that point that you have not actually done any damage. You are just approaching. So that's potential tissue damage. And so what does our brain want us to do? Our brain wants us to stop, to change our behavior, to stop pulling back on our finger, to let go so that we don't actually damage our tissues. But we've had pain and there's no tissue damage. So that is an important concept that we need to understand and that our patients need to understand. So another way to look at how pain differs is to look at the difference between acute pain and persistent pain. In acute pain, I'll go back to that ankle injury analysis or story that I just gave you. Acute pain is very much a perceptual experience about what has changed in the tissue. It's driven by the nociceptive changes in the tissues, by the tear in the ligament, by the change in the pressure within the nerve receptors at that point. There's also changes within the chemical receptors at that point because of the flood of biochemical processes that are involved in producing an inflammatory response, right? And so when we have acute pain, it makes sense to look for the bit and piece that doesn't work. It makes sense to target the tissues. It makes sense to do a really good biomechanical assessment. And the biomedical model works really well here, right? In persistent pain, we are failed by the biomedical model. The biomedical model doesn't help us necessarily understand the complex picture of persistent pain. And you'll notice in this talk that I talk about persistent pain and not chronic pain. Persistent pain just means that the pain has lasted longer than it should. Chronic pain means that it's never getting better. It's permanent. And that is something that we want to move away from in our belief system as physiotherapists, as clinicians, and we want our patients to move away from that belief system as well. Because as long as neuroplasticity is present, we know that we can change the pain system. So persistent pain is actually experienced pain as a result of changes in the central nervous system. There's no single cause, it's complex, and we need to again measure the complexity of that pain, not only looking at the tissue involvement, and again, it's not tissue acute injury at that point, but it's usually that the muscles are tight or the joints are tight or things are weak. That may be the tissue sort of involvement or input, but there's also an experiential involvement in the nervous system, and patients may be stuck in a catastrophization substructure of where they're just kind of staying in the piece of this is the worst thing that's happened, that sort of catastrophization. This is the worst thing that's happened and I'm not sure I can cope with it. Or they may be stuck with a lot of fear of re-injury, for example. And so we have to again measure those pieces to really start to understand why this pain has persisted. In order to do that, we need to change our model. We need to use a biopsychosocial approach, and we need to target the nervous system and target central pain mechanisms versus targeting just the tissues. There is a lot of research over the last decade and more that looks specifically at the difference between persistent pain and acute pain. And this research study by Hashmi et al. In 2013 has shown that with a functional MRI study of the brain, we actually see that persistent pain involves different areas of the brain's neural matrix than acute pain. All right, we can actually see those functional changes in the brain as people are experiencing pain in those different states. And so what we see is changes within the functional MRI more in the emotionally driven areas, so more in the limbic system with persistent pain. And acute pain is more experienced in the sensory motor cortex, for example, and not so heavily involved with the limbic system kind of coming into that. All right. And so we need to understand that we can start to look at the difference in acute pain and persistent pain in an objective way using functional MRIs. So if we take a tissue-based physical structure approach to persistent pain, then this is a very ineffective and often counterproductive approach. So we need to change our approach.